And I think what you're speaking to is the biological diversity that exists in all people. We're all individualized. Their reactions can vary greatly for people who've been taking these drugs. And we don't know when it's going to hit that curve.
Because it's individual, We can say it with some, and I have that in the book too, like a range where it usually happens.
Okay.
So we could say that for Zoloft, for example, it's usually between 25 and 50, I would say, meaning some people can get all the way down to 25 milligram-ish before withdrawal starts to hit. And the both motivating and demotivating part of the story is that you're not halfway at all, even at 25. Even if you came from 200, that's what we got to understand. Like 100 isn't half of 200, 50 isn't half of 100, and so on and so forth. So whereas some people will definitely react with withdrawal symptoms at 50 milligram, and some people also higher. And that's where the element of it varies comes in. And we don't know how to say in advance, you're going to react at 25 and you're going to react at 100 and you're going to react at 50.
And I think some of the things that we're seeing where there's crisis events, we're seeing under these conditions where somebody abruptly stops their drug. Dose increases, dose decreases, right? Those changes, those shifts have induced crisis events in our country. And I think they're factors associated with suicide and violence, among other psychiatric hospitalizations. So it's really important for people to know, and I want to really emphasize this, is for the overwhelming majority of people who are getting off the drugs with the standard physician or nurse practitioner, they're following these protocols that were provided to them. And those protocols can be like going from 80 milligrams of Prozac to 40 milligrams of Prozac to 20 milligrams of Prozac to taking it every other day, right? What is, I know everyone's different, but what is that going to do to the average person?
Well, the average person would be able to go from 80 to 40 with no problem because that part of the dose has no effect because the receptors are saturated already. So you can't just keep on adding, well, you can keep on adding a drug. There's no limit to that, but it doesn't have any effect because whatever it's doing in the brain is already saturated at a lower dose. So the average person would definitely be able, this is not medical advice, obviously, blah, 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 but most people will be able to go from 80 to 40. Some people will be able to go from 40 to 22 without, because that part of the drug still has no effect. There's no difference. But from 20 to 0, you can be absolutely sure there's a massive, dramatic decrease in whatever the drug's doing. And that's what causing the body to scream at you with withdrawal, really just asking you to take it again. Because you've not because it needs it or likes it, but because you've introduced too big a change in it for it to keep up.
And so we induce that withdrawal, they go back to the doctor. And then the doctor says, this is why you need to be on Prozac.
So that withdrawal reaction is then taken as proof that the drug works, is still necessary, that you're not yet ready to come off it, which can be a profoundly demotivating.
And it's bullshit.
And it's bullshit. It's wrong. And it is. And it's demotivating because maybe that person has just been through a lot of therapy, made some changes in their life, really gotten into a place where say, I'm ready to come off this drug. I believe in it. I have the support system. Like that's a really hopeful, for most people, a hopeful part of their life. And then that's just completely demolished with withdrawal reactions that are misinterpreted as relapse, because the definition of withdrawal symptoms haven't been updated in the stupid guidelines for years. So it still defines it as this, in the majority of guidelines, still defines it as this mild and self-limiting symptoms, and then they measure maybe 3, maybe 5, maybe 7 symptoms, and not the 80 symptoms that are on the list. So obviously, if you trust in your documents as a doctor, the official paper saying what the withdrawal reaction is, you kind of have to follow that, right? So it really comes down to changing those guidelines. 2 of the papers from my PhD was on guidelines. We were really just compared the evidence with what's in the guidelines. I just saw the huge, huge gap. So this is the problem or the story that I kept seeing, like people coming off the drug too fast because the guidelines say you have to do it too fast. Deteriorating massively, and then had this story just ingrained in them, built both in themselves and from their clinician, maybe their loved ones, that they still need it, and that's what causes this. And what usually happens is that I would say that the typical client at my clinic, 9 out of 10, has had this story. And when we just taper slower in this way, the hyperbolic way, nothing happens. Well, they get withdrawal sometimes, but nothing near the experience they'd had before. And as we talked about before over dinner, that's a funny illness that reacts to that way. It's funny that it reacts like and some underlying illness, that idea of something being there, wouldn't care how we reach a lower dose. So the fact that it doesn't appear when we go slower enough, and slower really should more be called gradual. It's not the time in itself that makes the taper correct. Like you could wait half a year on a dose and then make too big a reduction and it would still be an incorrect taper. So the thing that makes these sometimes year-long tapers is not the time in itself, is that we get limited when you reach that, we don't have them here, that steep end of the curve. We have to understand that the body can detect very small reductions. It's the difference between the doses that the body reacts to when it has to adapt. So when you reach the lower doses, but they're not lower, they're pretty potent, you're limited as far as how much you can reduce the dose, and that's what makes it take so long, because the body can detect very small dose reductions. So we really should call it more gradually instead of more slowly to come off.
So eventually, the person will get down to nothing at all, right? They're not taking anything.
Zero, yeah.
The absolute zero,
yeah.
right? And then there are people then who enter into somewhat like a more severe withdrawal at that point. They're vulnerable to what's called protracted withdrawal. Can you explain what that means?
I don't know why these things are all there. We're trying to do the same as calling them all sorts of fancy things. It's really just an incorrect taper. Like you introduce too big a difference and too big a change for the body to keep up. That's what causing withdrawal. And the protracted element really is just that it keeps on going. Really. So if you're in protracted withdrawal, I would say it's not that complicated. You made too big a shock for the body to keep up. And if you stay in that too long, that's where it gets really, sorry?
Yeah. So do you then reinstate the drug?
That's the big question. Because there seems to be a window of reinstatement. We don't know how long it is, and obviously it varies, but it appears that there is a limit as to how long you can stay in withdrawal and the body's still accepting that you take the drug again. And that's really the tough part of it. I have a lot of clients coming that they only contact me after they've tapered incorrectly and just been waiting for the symptoms to resolve, and they didn't. The big question is, okay, will the body 2, 3, 4 months, whatever, into being withdrawal, will it accept taking the drug again? And sometimes it will, sometimes it won't, and sometimes it gets worse, like because you've kindled your nervous system now, so now it reacts to the drug again. It's a very unfortunate situation. So just to say that the solution to severe withdrawal, if you happen to make a reduction that really causes you to go into withdrawal, is reinstating. That's what the body's screaming for. That's what those signals are there for. It's trying to make you take the drug again, and then it stops. So withdrawal symptoms, severe, definitely call for reinstating. But if you stay in it for too long, it appears that you can kind of, like the damage has been done.
Is this damage permanent?
I don't think it's permanent. I think way more people than not heal from it, but the time frame can be incredibly, incredibly long. And we don't know a lot about how to do it. I think we're limited in how we can interfere with that system, because it's really a nervous system that really just is absolutely sure that there's danger ahead. That's why it keeps sending symptoms.
Yeah.
So I don't know how long it is, that window of reinstatement. In fact, I think nobody knows, but there's definitely an expert element in that, because we say there are 3 ways it can go. Either it works, you resume the drug, just disappears, or it doesn't work, or it makes it worse. But this is, I should say, this is not when we taper correctly and the withdrawal symptoms you get, even in a hyperbolic taper and following the principles, most people still go into withdrawal, but it's tolerable. It's minimized to a level that you can use your psychological strategies and your attention to kind of make it step into the background. These symptoms are too severe for you to do that. So just to stress the difference, part of coming off these psychiatric drugs is obviously we're trying to taper in a rate that makes the body not go into withdrawal. But because of how the drugs work at the lower dose, there is almost always an element of managing withdrawal too, without reinstating, obviously. Protracted withdrawal is different. A very severe withdrawal is different.